I will start also by raising question to you and to Dr. Talib, because this is a new technology and probably it will change the concept. Now we are having new machines in the angio suites which can do CT scan as part of the angio suite. And CT can be done even with CT angio with perfusion, and even very recently rapid software can be put on these machines. If you are having in your center one of these machines, would you go for the trend of door to angio directly, and then you will do everything for the patient? I mean, you will take the decision in the angio suite itself. If the patient is having no large vessel occlusion, so you will go for thrombolysis IV. If it's having a proximal occlusion, so we will go for thrombectomy. So you can do also with the rapid software the mismatch. So if you decided that there is beyond the 6 hours or even up to 24 hours, you can do the mismatch immediately, and this will save a lot of time. You think this is the future of in these centers which are having these fancy machines to do the decision?
The question is, I think, for Dr. Talib or for me?
We can start with Dr. Talib because he's the interventionist.
He's the expert.
Well, I think, having these machines will be a luxury. I mean, if we have it, why not? It will save time, but it will create a burden on the team because he will be available around the clock. That's it. That's the only issue.
Yes, but of course, with any new technology, probably things will get cheaper and will get widespread. I think. I mean, when I think about this, you can take a decision in 15 minutes or so, and you will have all the information, and you can take immediately the decision. I guess this would be a great thing. As you said, it's very expensive. It's very it's difficult to of course offer in everywhere, and it will be a big burden.
I mean, it will really save time, and patients will have better outcomes, definitely. But the problem is to recruit the people around the clock to be available. That's the only issue I'm afraid of.
Yeah. Would you like to add anything, Dr. Firas?
As Dr. Talib said, it's the manpower, sir. Dr. Prof. Hani, it's the manpower issue with the manpower.
Yeah. So we will start with the questions. This is almost a case. The 57-year-old male patient with thalamic stroke with 4 months duration. During admission, the power in the upper and lower limb were 0/5, no sitting balance. Now the power is 4/5. Still sitting balance is fair and standing balance is poor. It's getting physiotherapy session every day. His progression is very slow. Is it possible to get full recovery? I think Dr. Mohammed, you can answer this question.
Well, the improvement of a stroke generally is multifactorial. So, a patient with risk factors, someone with active physical life, and someone that had good rehabilitation, different from someone that has only outpatient rehabilitation while he's needing actually for inpatient rehab. So, will he get a full recovery? Yes, it is possible. He might get the full recovery. I'm surprised that he had 0 out of 5, and now he's actually has standing. Still, I mean, balance was fair. So I would say that still don't judge it now. Look at it and about for ischemic stroke, we say 1 year is fair to say whether the patient will improve after or not. For hemorrhagic, probably is a longer time. So I would say there's no good answer to say that get the full recovery or not. That's something that I would say headache.
I don't know. This question is not very clear because, but it's what is the time frame to get the antidote? I don't know what he means by antidote after stroke attack, and how long the recovery time after stroke, and what we can take the immediate measure at home after stroke attack. Is it only transferring the patient to the hospital immediately?
I think he means the TPA by the antidote.
Maybe, yes.
Yeah.
So, any Dr. Talib, you think?
Well, so whenever you have a patient or anybody that you know will suffer from a neurological deficit, whom you think it's a stroke, yeah, it's advisable to bring the patient directly to the hospital. Now, depending on the last time that patient has been seen well, if it's less than 4 hours and a half, and depending where the clot is, if it's in a large vessel, I mean, he will benefit from, and if there, I suppose that there are no contraindication, that patient will receive the antidote, as you said, which is basically the TPA. He will get it. And in the meantime, if there is a large vessel occlusion, he will go for endovascular thrombectomy. Now, if he's beyond that, he will not be eligible to receive the TPA. Okay, but if he fulfills the criteria of all the studies we just mentioned earlier, and he's a candidate for thrombectomy, he will benefit from thrombectomy.
Okay. I guess this question can be directed to Dr. Firas. He's the one for discuss the issue of the code. This is the and why so many ER physicians are reluctant to do thrombolysis despite they are encouraged or they are doing this very well with STEMI.
Actually, it's I just will mention here. I remember when we trained in neurology, you know, the professor, part of neurology, you have to work with internal medicine. So the issue that the fear from the diagnosis, to overcome this is just needed training. If we train them, convince them, put for them the algorithm, sure, they are the cornerstone in the treatment and in the diagnosis of stroke. We should help them to overcome these obstacles. I mean, this feeling that the fear from treating patients with stroke. Because as the question mentioned, that the patient, they are treating patients with MI and they are giving tenecteplase, but with stroke, they just stop. So training them in the diagnosis and involving them in the team, sure, with the training, with the regular training, sure, there will be no reluctance to giving thrombolysis by emergency doctors. And actually, I think outside who trained in Western countries, the thrombolysis even given by the ER physician. So it's just a matter of training and helping them to overcome this.
I guess this is for Dr. Talib. Why there is a window for thrombectomy?
Why there is window for thrombectomy? Yeah, well, because that will be dependent on the tissue that has been affected. I mean, as I discussed in my presentation, you basically look for small core of infarction. In case of large infarctions, I mean, the outcomes for thrombectomy will be very bad. So that window is basically subjective. Because sometimes you will have patients coming with, let's say, a short period of time, okay, but with big infarction. So there's no tissue to be salvaged. However, you will have patients who had a longer period of time where they have been seen well. But if you do the imaging, you'll see that we have tissue that can be salvaged. So it depends on how much tissue is being salvaged. It can be salvaged based on the imaging findings. And that will be my answer for your question.
Okay. I guess this is an important question, and I can even also share the discussion with this. Do intervention cardiologists and vascular surgeons are performing thrombectomy in wherever in UAE, in Saudi Arabia, in Bahrain, in Egypt? So let's get the answer from everybody.
Yeah, I mean, in UAE, we have many body interventionists are doing thrombectomy. But cardiologists, I don't no, I didn't come across anybody who's doing thrombectomy in UAE.
And what is the main radiologist, neurologist, neurosurgeons? What is the main, I mean, the big number of interventionists in UAE?
Yeah. So here it's variable as well. Now you have radiologists, but I think they are a handful actually. The bulk, I think they are neurologists. Okay, I'm talking about one center where they have 5 neurointerventionists. 3 of them are neurologists. One of them is a neurosurgeon, and the other one is a radiologist. Okay, most of the centers I've seen actually, the bulk will be from a radiology background. Okay.
And what is the situation in Saudi Arabia, Dr. Muhammad?
Yeah, so do intervention cardiologists. Actually, I'm not aware that anyone intervention cardiologist do thrombectomies, but they are doing carotid. In Medina, we started doing carotid by cardiologists. To be honest, Rida was there, the well-known cardiologist interventionist, and he was doing for carotid. I remember one case where he chased a thrombus from the internal carotid artery, but they are not doing this on a regular basis. That's my vascular surgeon again for carotid, but I'm not aware of from there. The main bulk, different from one center to another. Where I trained in King Fahd Medical City, they have 6 interventionists. They're cocktail, where they had 1 neurologist, one neurosurgeons, and 4 neurologists. So probably neuroradiologists are still leading this. And I don't know why the intervention cardiologists are not being part. I know that there is outside Saudi Arabia, there are calls for intervention cardiology to be a part of thrombectomy, but I'm not aware of that here. Of course, the training background is different. In Saudi, it requires 2 years to get certified for to do neurointervention procedures. Probably longer.
And in Bahrain, Dr. Firas?
In Bahrain, best of my knowledge, it's only King Hamad University Hospital offering thrombectomy. We have 3 interventions, 2 intervention radiologists, and 1 neurologist, trachologist.
Yeah. I guess also in Egypt, the 3 are working, the radiologists, the neurologists, and the neurosurgeons. The number of neurology actually is increasing rapidly, but still, I guess the radiologists are dominating. I will answer also the issue of cardiology, because I attended a meeting about this issue, whether cardiologists are allowed to do intervention, especially in the intracranial vessels. Actually, many people are against this because they should have neurological background, study of the anatomy, of the detailed imaging and everything. And also, but the issue is because there is, after the era of the thrombectomy, the lack of in many centers of people to do thrombectomy, especially that it's reimbursed in many European countries. So I guess in some European countries, they can allow some of the cardiologists to do just thrombectomy and nothing else. Of course, aneurysms and AVMs and so on. This is for the best of my knowledge.
May I add something?
Yes, definitely.
So the norm for doing interventional neuroradiology or interventional neurosurgery is through 3 pathways. either you have to be a radiologist, neurologist, or neurosurgeon, as you mentioned.
Exactly. Exactly.
Now, the pathway would be as follows. I'm talking about North America. So you have training in radiology for 5 years, and then you have to pursue diagnostic radiology so you can understand, the neuroradiological aspects of radiology, and then you pursue neurointervention. Now, this is variable. You can do 1 year or 2 years of neurodiagnostics, and 1 year or and 2 years followed in neurointervention. Now, in neurology, you do 5 years of neurology, and then you do 1 year or 2 years of stroke neurology, followed by 1 year or 2 years of neurointervention. So that is variable. That's up to you. In case of neurosurgery, it's in Canada it's 6 years program. In US it's a 7 year program right now. Here's the thing: you have to do open vascular surgery, which may span from 1 year to 2 years. So that will be 9 years in US and 8 years in Canada. Now, the open vascular surgery can be hybrid, for which the fellow can do open and do vascular at the same time, or he may do 1 year of open vascular and 2 years or 1 year of
Yeah. Yeah.
endovascular. So it's variable from one state to another.
I think eventually there will be a definite solid specialty of neurointervention with a background either from neurology, neurosurgery, or radiology. And as long as you are fulfilling the whole criteria, you are working as a neurointerventionist regardless of your background.
Yeah. Now, there are some prerequisites actually before going into any endovascular fellowship. I mean, for me as a radiologist, I have to have done around 100 cases of cerebral angiograms.
Yeah.
Before going into neurointervention. So I think it would be ideal to ask somebody who is from outside the field to go, and just because he has the technical aspect of it, but he doesn't have the knowledge.
Yes, exactly. That's why many people are against the cardiologists to go and do this. Now, another question regarding what are the risk factors of stroke? I guess Dr. Muhammad can answer this. Dr. Muhammad, unmute yourself. Yes.
Yeah, my apologies. So the risk factor of stroke, we usually divide it into traditional and non-traditional. So traditional risk factors can be modifiable and non-modifiable. So modifiable factors like hypertension, diabetes, smoking, obesity, lifestyle, and there are non-modifiable like aging. These are generally the risk factor traditional. There are non-traditional risk factors related to, for example, cardiac diseases and, for example, thrombophilia, diseases of systemic disease like systemic lupus. So there are different factors for non-traditional, but we need to focus on the fiber risk.
I guess there are so many questions popping up, so probably I will take, for the sake of time, some of the questions, and I hope the speakers can answer in the chat box the rest. So I guess this is an important question. If the patient are developing stroke despite taking NOACs, doesn't that mean they are not as effective in preventing stroke as we previously thought? Stroke on NOACs.
You want me to answer, Professor?
Yes, Dr. Firas.
Actually, in any recurrence of stroke, the first step to do is reinvestigate the patient regarding the pathophysiology of stroke. Is it embolic? The second stroke, is the source from the heart or not? Regarding NOACs and changing between NOACs, actually there is no a clear recommendation. Whether if the patient on NOACs, you change, let's say he's on dabigatran, you change to Xarelto if he's having recurrent strokes. There is failure, there is percentage of patients who they are on NOACs or on anticoagulant, and they will have stroke, embolic stroke. And according to study, I remember it's published in Annals in Urology, I don't remember the name actually, but it states that those strokes, those patients on NOACs, even if they have embolic stroke, it will be less severe than patients who's having embolic stroke, but they are not on anticoagulant. So first of all, you should know the pathophysiology. Is the stroke embolic in origin? The second stroke, I mean, the recurrence of stroke. Then accordingly, you will decide. And if anyone from the panelists want to add, it's fine.
Any further comment?
I would like to comment saying that you might have a different mechanism as mentioned by Dr. Nasri. So someone with NOACs might have an initial embolic stroke, then he developed a lacunar stroke because of diabetes and hypertension, and NOACs does not prevent that. And I think that the compliance of the patient, you might think of patient is taking NOACs, but he's non-compliant. Sometimes we know that most of NOACs does not have interaction, but interaction with medication and food is important as well. So we look at different aspects as well.
Also, there is, I mean, in the same context regarding the NOACs, I guess Dr. Firas also can answer why the expert consensus differ in giving TPA when patients on NOACs. Is it because timing to administer the antidote, and what is your approach for your patients on NOACs?
Now, first of all, to answer the last question, what's the approach is we are strict to the guidelines. Still, NOACs is one of the major excluding if the patient is not taking NOACs in the last 48 hours or even 72 hours. If the patients with renal failure, in case of dabigatran, we exclude them from thrombolysis, and if they are a candidate for thrombectomy, we shift them directly to thrombectomy. This is one. Regarding the conflict between the expert, because there is no high evidence studies support the use of the antidote before giving the TPA. The last study published in a neurology journal was like an experience of the neurologist in New Zealand, and it supports the use, but it's just an observation study. And in this study, I remember the percentage of usage of antidote in a neurologist, between a neurologist, raised from 1 to 6%. So in the first year, it was 1% of the neurologists in New Zealand use antidote, adirosozumab specifically, while they are giving TPA. And why? The conflict regarding they vote against indexinate alpha, because adirosozumab, it's giving us bolus. It's coming as two needles, and you give them as bolus. While indexinate alpha, it's an infusion, so it take long time. And actually, to answer this question, I refer you to this paper because it discusses it in deep. One of the issues regarding the antidote is that the rebound elevation of the drug level. In one study done in Germany, they found from 75 patients, 11 patients, the drug level was fluctuating. Even after they put a cut line of 12 hours, and they found that Xarelto level is elevated, returned to be elevated after 12 hours. And the same with other NOACs. So it's not a practice, actually. It's not still, what I suggest is what's mentioned in the guidelines, even in the American guidelines and the Canadian guidelines. If you have the highly specific investigations, including thrombin time for dabigatran, and the factor 10 level regarding the Xarelto and the Pexaban, with all the parameters of the coagulation profile within normal, they mentioned it's reasonable to give. But if you don't have, and actually I don't know, it's not available. The other issue face us with NOACs that we don't have a POCT test. In INR, you have a POCT test, which is valid, and we know so you can get the result of INR earlier. While in the NOACs, it will take long time. You will send the investigations and to the lab, and there is a study regarding POCT test, but still it's not studied well. It's used in some centers in Germany, according to my knowledge, according to what I hear from one of the writer of the paper. I point for it. He's from Germany, and I remember they are using this POCT, but still it's not until now it's not valid. That's why, and actually it's strict to the guidelines. This is the answer.
Okay. I guess this is for Dr. Talib. Do we need a score for hemorrhagic stroke after thrombolysis or thrombectomy?
Can you repeat the question, Dr. Hani? Do we need
a score for hemorrhagic stroke after thrombolysis or thrombectomy?
Not really. Not really. I'm not aware about anything like that. But I mean, we do measure the volume of the blood that is seen in CT scan, but it is of no value. I mean, I see many people are calculating it, but I mean, it's of no use clinically.
Yes, I guess we had some research about scoring the staging of hemorrhage after TPA, but I guess as you said, it's not very valuable because sometimes it turn out to be massive, or sometimes or depends on many factors.
I mean, what you care about is there is no progression of the bleed. That's it, whether it's stable or not. I mean, the more bleed, the more poor prognosis the case will be.
Exactly. I guess, Dr. Mohammed, you can answer this question regarding the NIH stroke scale. Who is the best to do the NIH stroke scale with the patient? Because you know, different in different setting, in different, it depends on the personnel. And
yeah, I would say the trained one. That's the answer. With a nursing, physician, resident, consultant, a trained one, I would say, is the best. And I worked in a hospital where nursing doing the NIH score, and we helped them. And in our hospital now is the resident doing the scoring. So I would say that trained one.
Okay, I guess this is Dr. Firas can answer this. How far does the tissue window concept can apply for the posterior circulation, both theoretically and practically?
In the studies, they didn't, Dr. Hani, the tissue, the CT perfusion function, or even the CT, it's not too much applied for posterior circulation. Instead, they use what we call a posterior circulation aspect score in selecting patients for thrombectomy. It's also a score of 10, and you remove one by one according to which region, involving the thalami, the brainstem, cerebellum, and other regions of the posterior circulation. I remember a case in our hospital where we did CT perfusion, and actually we were concentrating the patient. He was intubated. They brought the patient unconscious, intubated, for possible thrombectomy. And I remember that we did CT perfusion, and it showed that the patient there is stroke shown in CT perfusion. The sensitivity, sure, it's less than the anterior circulation, but I'm not aware if there is a study exactly studying the CT perfusion concept in posterior circulation only. Most of the studies involving the posterior circulation as part of the anterior circulation. Even in thrombectomy, we don't have a dedicated study studying only thrombectomy in posterior circulation, apart from a last study, basic study published last year, study only thrombectomy in basic in posterior circulation. Actually, I don't remember that there is a dedicated study regarding definition of the CT or use CT specifically for posterior circulation. It's part of the anterior circulation. All the studies include them as part of the anterior circulation studies.
I will pick some few questions. I said just because of sake of time. Can brain repair itself after stroke? Dr. Mohammed Al-Johani, can you answer this?
What is it?
can brain repair itself after stroke?
Yeah, sure. It's not all gone. So those that treated early, we looked at outcome after 90 days. So brain takes time to recover sometime, but yeah, it does. The brains recover with time. It is different uh, timing from ischemic and hemorrhagic. As I mentioned earlier, that sometimes ischemic strokes takes a year to see the improvement, and there is a concept of plasticity in the brain where the brain chooses to use other areas for other functions, helps in getting the patient use of different area of the brain. So yes, the answer is yes. It will recover with time, and it does recover with time because they have sometimes there's a shock brain that there are areas that oligemic, but it's not lost and recover.
I may add, I may add just the neuroplasticity.
Yeah,
It's very important. It's very important. So it's depend on the neuroplasticity of the brain.
you think we can enhance neuroplasticity either before stroke or even after stroke? So, you know, sometimes there is some research, of course, especially yes. experimental animals, to enhance plasticity.
Yeah,
but
still, Doctor, all the studies regarding these agents fail to show any in animals, yes, but in human, no study until now. Till now, I don't know if maybe a new study published. According to the best of my knowledge, no study show it's any benefit in human.
I guess Dr. Talib can answer this. What is the future of stroke treatment and stroke prevention? You think there will be any new technology, any more intervention?
Well, unfortunately, I'm not a futuristic guy, to be honest. Yeah. But you never know, yes. I mean, I think people are looking into prevention more than treatment right now. That's why we are talking. I mean, trying to focus on primary prevention and secondary prevention when a stroke happens. So I think the focus will be on the prevention. I don't know if my neurologist colleagues, Dr. Mohammed and Firas, agree with me.
Yeah, sure. I would say I would say optimistic, and I would say that time probably the time his brain probably will move to image brain, and we probably drop the clock as imaging. Still will be time brain mean, but I would say will be move on to imaging rather than timing alone. So everyone will have his own time. Time will be calculated based on imaging. That's what I think the future is heading. And if we calculate appropriate time, everything will be open. TBA, mechanical thrombectomy. And for prevention, I'm not really sure that we will have a lot of advances.
Actually, I think the use of polypill, a lot of studies by the World Stroke Organization using of polypill to make the medications, the prevention medications, available for even in low-income countries, because as we know, stroke is a preventable disease in 80%. So preventing stroke is one of the important things that we should work. And I'm sure a lot of studies we start with. We know that there is the study of Berlinta use of the new antiplatelets with aspirin. So there is a hope actually regarding the more development in the prevention of stroke.
In the same context, Dr. Firas, because somebody is asking what treatment should be given in the first hour before shifting the patient to special center? Can we give Plavix or other antiplatelets? You said Berlinta. I guess this is very important issue, especially after the new trials of dual antiplatelet, the point, the Thales, and all these studies regarding the dual antiplatelet, and even loading with a high dose. But I think this is for the second prevention for recurrence.
Sure, if you are shifting the patient for acute treatment, you should not give. And I mean, if he's for thrombosis, you should not give. But regarding secondary prevention, as you know, Prof. Hani, We have the chance in Chinese. This is the oldest one. They use
Yes.
aspirin and Plavix. And we have the Point in North America, which also use aspirin and Plavix. And then we have the Thales study, use Berlinta and aspirin. And it showed that it's an important category in this study is that Berlinta with aspirin may be more effective for those patients with intracranial stenosis.
Yes, yes.
Those, the ICAS patients.
Yes, yes.
Actually, those I will say in our region, it's an underestimated pathophysiology of stroke. Actually, in King Hamad University Hospital, now we are running a study to check ICAS in stroke and its incidence in Bahrain and comparing it to non-Bahraini. And in the literature, actually, I found just one study in Egypt, Prof. Hani, one study in Iran, one study in Israel. They study part of the included patients were Arabic. So dual antiplatelet, the superiority of or using of Berlinta is more trending, but actually, according to Thales study, it's only superior in this category of patients with atherosclerosis, with ICAS.
Yes, I totally agree with you, especially as you said, with this subgroup analysis of the intracranial stenosis patients, because it's very common in our region. In our study in Egypt, which we published in Stroke Journal, it's 27% of our patients are having intracranial stenosis. So it's quite common, and I guess, as you said, it's prevalent in our region. So probably if we have a drug which is effective in this category of patients, I guess this would be important. I think we can take the last question, and this is also a very important question for Dr. Talib. You think that thrombectomy will be the gold standard for treatment of stroke?
Will be the gold standard?
For the treatment of stroke? Because, with the trend of the best outcome, of the very good outcome for different studies for thrombectomy. So many people are encouraged that the thrombectomy and sending the patient immediately for catheterization will be the standard practice for a stroke. And I have a comment after your answer.
Yeah, currently it's a standard of care. You consider thrombectomy, but it will be individualized based on the imaging finding, actually, and the artery involved. Okay, but not everybody who comes with a stroke will end up having a thrombectomy. It depends on how much time he's connecting to the hospital or the center.
Yes, I totally agree with you, because it's large vessel occlusion will represent between 20 to 25% of the all stroke patients. So what about the rest, the 70% even for those patients? Probably they will need more thrombectomy. Of course, there is a debate about M2 and other distal regions, if they are occluded. But
yeah.
But immediately sending the patient to angio suite will waste time. And also, even if the patient is having large vessel occlusion and coming in the window, early in the window, he should be thrombolized intravenously. And all of the studies, including Hermes analysis, including many studies, proven that this will benefit the patient on the long term if the patient proven to have thrombectomy, to have large vessel occlusion, and will do thrombectomy afterwards. The most important thing, not to waste time, as you just said.
Yeah, if you look back at the studies that have been done and published in 2015 and 2018, they all looked at the large vessel occlusion and the use of venous or aspiration. Thrombectomy, basically, to retrieve the clot. And if you look at the vessels the studies treated, were proximal vessel, the M1, basically, for the middle cerebral artery. Now, there's always a debate whether to go distally in an M2 or an M3. There are some studies showing interventionists or neurologists going to treat M2s or M3s, based on the clinical presentation the patient is presenting. Personally, as I said before, if I have an NIH score that is low, but the patient is aphasic, I would give the patient a chance to go in and retrieve that clot. Okay, because I believe the presentation is really because it's not being treated, and that's what many or some interventions will do the same as well.
Exactly. Lastly, I would thank our three eminent speakers, Dr. Mohammed Al-Johani, Dr. Talib Al-Mansouri, Dr. Firas, and we would like to see you next time and to have more fruitful discussion and more benefit from the discussing the different aspects and different issues of stroke. Thank you and see you soon.